Hello, my name is Miguel. I'm going to talk about canagliflozin and renal outcomes in type 2 diabetes in nephropathy. Introductions. Type 2 diabetes mellitus is the leading cause of kidney failure worldwide, but few effective long-term treatments are available. In cardiovascular trials of inhibitors of sodium glucose transporter 2, exploratory results have suggested that such drugs may improve renal outcomes in patients with type 2 diabetes.
This trial is really important because diabetes and diabetic kidney disease are 21st century epidemics. There are more than 400 million people with diabetes around the world at the moment, and 40% of these people will get kidney disease. Once they've got kidney disease, they're at very high risk of kidney failure, of heart attack, of stroke, of heart failure, and of death. So with this trial, we took a drug that's available today for lowering blood sugar levels in people with diabetes, but which we thought may well have additional special beneficial effects for the kidney. And we gave it to people with diabetes who already had evidence of kidney damage. We took 4,401 of these people from over 30 countries around the world, and we gave half of them this drug, canagliflozin, and the other half an identical placebo. We found dramatic reductions in the risk of kidney failure and related outcomes in people with diabetes who were treated with this drug compared to those who just got a placebo. Not only did we reduce the risk of kidney failure, but we also found that the risk of cardiovascular events like heart attack and stroke and heart failure were reduced dramatically as well. These results are really important. There are already more than 3 million people with kidney failure who need dialysis around the world today, and that number is projected to double over the next decade or two. With this treatment, because diabetes is the top cause of kidney failure in most countries, we have the opportunity to prevent many of those people from ever reaching kidney failure. I see so many patients who have had diabetes for some years and who start to develop signs of kidney failure. Until now, we've, for many of these people, had to just watch them as they progressively developed kidney failure. They suffered from the cardiovascular complications, things like heart attack and stroke, and ended up, in many cases, needing dialysis treatment just to keep them alive. With this treatment, for many of those people now, we can offer them real hope and a better future.
Applications in medicine. Develop new treatments that can prevent or delay the progression of chronic kidney disease. ISGLT2 are drugs that improve glycemic control in patients with DN2. At the moment, they are marketed empagliflozin, canagliflozin, and dapagliflozin. Pros and cons. Pros: reduce a kidney disease, and cons: deaths, myocardial infarction, stroke, hospitalization for heart failure.
Now let's move on to diabetes. There were the DECLARE results. How do they fit in?
DECLARE was an interesting study. It looked at an SGLT2, a drug that in part increases loss of glucose in your urine. We think about these drugs to alter glucose levels, controlling them better, but in DECLARE we found that in fact these could alter the one's likelihood of developing either heart failure or alternatively developing renal insufficiency, kidney problems. The drug was not effective in preventing development of atherosclerotic disease or coronary disease. But for patients, my perspective is, if you tell a patient, I can control your sugars better for a diabetic patient, but I can also reduce your likelihood of developing heart failure or kidney disease, two of the things you worry most about, that's a win.
So does this mean we should also be thinking about treating heart failure or preventing heart failure and renal disease in type 2 diabetics?
Yeah, I think it's exciting. We have thought traditionally about diseases in one box or in one dimension. We have drugs that lower glucose and we thought about them as diabetic treatments. The realities are these drugs have multiple effects, as we're seeing in DECLARE. reducing one's likelihood of developing heart failure, improving one's kidney function as a function of time, or not preventing worsening of kidney function. So I think we're thinking about now these drugs, how we're treating a whole diabetic patient, not only their control of their glucose, but looking at how it might affect their heart as well as their kidneys.
Great.
ISUS network. At the time, 4,401 patients had undergone randomizations with a median follow-up of 2.62 years. The relative risk of the primary occurrence was 30% lower in the canagliflozin group than in the placebo group, with event rates of 40.2 and 61.2 per 1,000 patient years, respectively. The relative risk of the renal specific composite of end-stage kidney disease, a doubling of the creatinine level, or death from renal causes was lowered by 34%, and the relative risk of the end-stage kidney disease was lowered by 32%. Conclusions. In patients with type 2 diabetes and kidney disease, the risk of the kidney failure and cardiovascular events was lower in the canagliflozin group than in the placebo group at the median follow-up of 2.62 years.
So, I mean, the CANVAS trial was set up to test the safety and efficacy of canagliflozin in diabetes, and the main manuscript itself was actually published 6 months ago. What they described there was an important benefit in diabetics on 3-point cardiovascular MACE, but importantly there seemed to be a real benefit in one of the secondary endpoints, which is heart failure. And really this is consistent with what's been seen with some of the other SGLT2 inhibitors, and it's really exciting from a cardiovascular perspective and a cardiologist or a clinician's perspective, because heart failure is one of the biggest problems for diabetes, that despite having good glucose lowering management, we've not been able to previously see benefits on in terms of the heart failure effects. So we then set out to really try and understand what was happening in terms of the heart failure events in this large randomised trial, and what we particularly were interested in is if they had a diagnosis of heart failure at baseline, did they still receive the same benefit and the same safety? And what we did see is obviously we confirmed that you do see a very high level of events in people who have got heart failure at baseline, and so by the end of the study 25% of them had actually had a heart failure event, and that was dramatically reduced by the SGLT2 inhibitors. We saw a borderline significant interaction between having a diagnosis of heart failure at baseline and the benefits, suggesting potentially higher benefits in patients that had heart failure at baseline. Well, look, there's a lot of interest in this area because of its huge implications worldwide. Obviously the burden of disease is there, and what's being now run is obviously prospective trials looking particularly at the benefits of SGLT2 inhibitors in patients with heart failure specifically. And so I think this will be something that will rapidly be changing practice. Well, I think obviously trying to understand whether the SGLT2 inhibitors actually work in different classes of heart failure. One area that we really struggle as physicians to look after and change outcomes in is people with heart failure but preserved ejection fraction. A very hot topic will be whether or not this class of agents may be one of the first to actually make a difference in that particular area. So I know these studies are actually being carried out at the moment. Certainly from a cardiologist perspective, I think we are now at a point where we need to engage much better with our endocrinology colleagues and actually learn about when we should be initiating some of this treatment and how we can partner with them to improve the outcomes of our patients.